Well, good afternoon. Good afternoon and welcome, everybody. It's great to see so many people here today for our celebration. So I'm going to throw things over to the Chancellor in just a second to introduce our special guest of honor today. But before we do that, I just want to say a few things about this award. So I suspect that many of us in the room right now have been in this room to listen to an outside lecture. Somebody bring in from a different university. I've listened to some great talks right here, and those have been fantastic. There's no shade on that. But a number of years ago, a few of us were speaking, Lori Sussel, myself, a few others, and we said we should find a way to recognize our stellar, outstanding faculty on this campus, recognize them and allow them to give a lecture to us and set that up. So that was the genesis for this particular event and this award. You can see the criteria here on the screen. This is down to the work. We select two CU Anschutz faculty members every year. They're recognized for their impact and their creativity in the field. And I think tonight you'll certainly see an example of that. Last year was the first year we started this tradition. I hope it's a tradition. Someone said to me today, if you do it 3 times, it's a tradition. So we're on number 2 right now. Last year, we honored and recognized Donna DeBelia from the School of Public Health and her work, as well as David Schwartz. This year, we honor and recognize Dr. Santoro, and you hear from her in just a second. And later this year, actually, in the beginning of next year, you hear from David Bentley. For those of you that are on campus and faculty members, you can look at that QR code, and we are still taking nominations for next year. So I would encourage you to think about that and some of our outstanding faculty and nominate them for this award. So with that, I'll turn things over to our Chancellor.
Thanks, Tom. And this has the title of the Chancellor's Award, but the fact of the matter is it was Tom's and Lori's idea. So thank you, Tom, and thank you, Lori, because I think it's a great idea. I think it's terrific that we have an opportunity to celebrate our own because we have a lot to celebrate. And tonight is one example of that. As Tom said earlier this year at our annual research awards ceremony, we recognized 2 extraordinary scholars, Dr. Nanette Santoro and Dr. David Bentley. And tonight we have the privilege of hearing from Dr. Santoro about a subject of which I know nothing. And there's a reason for that, which you can all probably figure out. Dr. Santoro holds the E. Stewart Taylor Endowed Chair in Obstetrics and Gynecology. For 15 years, she led the Department of OB/GYN at the CU Anschutz School of Medicine, stepping down early this year to devote more time to her menopause research and clinical practice. Dr. Santoro has been at the forefront of her field for decades and is widely regarded as a national leader and an innovator. Her contributions have deepened our understanding of women's health and led to significant advances in both research and care. Dr. Santoro's achievements have made a tremendous impact on this campus and around the country, and I know we're all eager to hear more. As we celebrate her, we also recognize the vital role of research in everything that we do. I'm fond of saying that we have 3 main missions, and they form kind of a virtuous circle: research, education, and clinical care. And it turns out that research, at least in my mind, is kind of the keystone of that arch. It's really the draw that brings the best clinical physicians to our faculty, and it's the draw that brings the best students to our education mission. So with that, I'm going to turn it over to somebody who exemplifies the best in what we do in research, Dr. Nanette Santoro.
Thank you. Thank you, Chancellor Elliman and Dr. Flagg. It's truly an honor to be able to stand here in front of you and talk about a thing that I could talk about all day, all night. Those of you who know me on my lab team know this is true. These are my disclosures, and I'm going to give you my summary points up front in case your attention span flags. But the human menstrual cycle involves a complex but robust series of events that I'm going to bring you through, and it culminates in an average fertile lifespan of about 40 years per woman. Reproductive aging is a process where there are compensated changes in menstrual cyclicity followed by uncompensated changes at the late stages that are significant. The late transition is a time of rapid physiologic change that merits further investigation and intervention, And obesity's impact on the menstrual cycle, fertility, and pregnancy is one of our next big challenges. So these are some of the areas that I've explored, and I'm going to focus on those two. So why study reproduction? Well, existentially, if reproduction goes awry, does anything else actually matter? I mean, that's kind of it for the species. So that was something that sort of attracted me to the field, because it's the essential thing that has to happen. So how did I get to the female menstrual cycle? Well, I'm going to bring you back to the 60s and 70s, because this was not something that you could even study until we had radioimmunoassays. And this is one of my science heroes who did this, Rosalind Yalow and Saul Bersin. They invented the radioimmunoassay. Saul did not get the Nobel Prize because he had passed by the time that Ros Yalow got it, but she did it at the Bronx VA. So all of my time at Einstein, I had a little postcard with her picture on it. This made it possible to measure hormones, because prior to that, we could only do things like bioassays. You would inject an animal with blood from somebody, and the hormone would have an effect, and you would try to figure out how much there was. And Rosalind Yalow's inspiration was this person. Does anybody recognize who that is? Yeah, and mine as well. How many of you read the biography by her daughter over and over again when I was a kid? So she was one of my science heroes. So sensitive and specific radioimmunoassays for reproductive hormones, this was the game changer that led to the study of the menstrual cycle. So no more bioassays. You could store serum. My lab will tell you I have serum in the freezer, maybe from 30 years ago, that they keep trying to get me to throw away. And you could do more frequent assessments of hormones instead of just looking at them weekly. And that then led to the first set of studies of the human menstrual cycle. And I want to walk you through this because this is central to everything else in my talk. So these hormone patterns are the day-to-day hormone patterns that occur. Men don't do this. They just kind of do the same thing every day. It's a little boring, but it works for them. Wouldn't work for the species. So here's menses here, and there's menses over here. So at the time of menses, all hormones are relatively low, and you can see that estradiol is low, but there's a little bit of a bump in FSH. It's very subtle. That then leads to stimulation of a follicle. Estrogen rises in an exponential fashion, and then it triggers a certain amount of estrogen exposure for a certain length of time, triggers an LH surge, and there's this massive discharge of LH that results in ovulation. There's a little secondary blip of FSH, unknown significance. In the 72 hours that this LH surge occurs, the follicle in the ovary transforms into a corpus luteum. Its entire enzymatic machinery changes, and then it produces progesterone in an approximately bell-shaped curve for about 14 days. And that reflects the adequacy of this progesterone curve, reflects the adequacy of the processes here. So spoiler alert for later. If there's no pregnancy, progesterone goes down. Most of the time there is no pregnancy, so that happens, and then a menstrual period ensues. And then again, within about 74 hours, the whole thing starts up again. So layered on top of this then became knowledge of the pulsatile nature of gonadotropins that drive the whole reproductive system. And this came from the Nobel lab, and Ernst Nobel was a very demanding taskmaster. He ran a rhesus lab in Pittsburgh, and he was having his postdocs were developing rhesus radioimmunoassays for gonadotropins. And they kept coming back with unacceptable variability. So he kept sending them back saying, you're doing something wrong, fix this. Why are these so variable? Well, it turns out that they were inherently pulsatile. And eventually they came upon that realization. And this is a classic experiment that just shows the requirement for pulsatile gonadotropins as well as pulsatile gonadotropin releasing hormone. So what you can measure in blood, and what I'm going to show you, are pulsatile gonadotropin patterns, but these are because the GnRH from the hypothalamus driving the pituitary gland is also secreted in a pulsatile fashion. So this is a monkey that has had a radiofrequency lesion in its hypothalamus, wiping out its ability to make GnRH. A pulsatile program is given back. LH and FSH are secreted in great quantities, and you can see those pulses very clearly. If you give it continuously, you overwhelm the system, you shut everything off. So it must be given in a pulsatile fashion. When it goes pulsatile again, there you go, they come right back. So that is an absolute requirement for both male and female reproduction, is that gonadotropins must be given in a pulsatile fashion. That discovery has really transformed medicine and was a huge reproductive discovery. So Lupron is one of the most widely used medications in the world. That is a GnRH agonist. It gives a continuous signal from the reproductive system and shuts off testosterone production for prostate cancer, shuts off estrogen production, treats endometriosis. And GnRH itself was a magic bullet treatment for people with GnRH deficiency, which is somewhat more rare. But this then made the pathophysiologic mechanisms of reproductive disorders much more clear. Roger Guillen and Andrew Shalley were awarded a Nobel Prize for this discovery. Then entered my fellowship with Bill Crowley in the Crowley Lab at Mass General, where I, along with colleague Marco Filicori, and where Maggie also did her fellowship at the same time, were tasked with coming up with the pulsatile hormones that were driving the reproductive program. So this superimposed on that day-to-day program, now you can see little snippets of time where blood was taken from women every 10 minutes to elucidate that pulsatile gonadotropin pattern at different windows of the cycle. So this is the early, mid, and late follicular phase, mid-cycle with that huge LH surge, and the early, mid, and late luteal phase. And there are some differences in these patterns that are meaningful. As you go from the early follicular phase to the mid phase, you can see these pulses are a little bit smaller. They get a little bit bigger here, and then they just go crazy at the mid-cycle surge. And this is a point where there's just sort of asynchronous GnRH secretion in very large amounts and huge amount of LH output. Then in the early luteal phase, under the influence of progesterone, you can see that these pulses slow down. So when we see changes in the pulsatile patterns, and LH is much easier to see than FSH because it has a shorter half-life, we can infer that if there's a bigger pulse, either there's more GnRH, the pituitary was more sensitive to GnRH, or it's a combination of both of those things. If we see a smaller pulse, less GnRH, a less sensitive pituitary, or a combination of those things. So what happens, my first task after fellowship and in my early career was to see what happened with reproductive aging, because there was not a lot known. And there were no systematic investigations really of perimenopause in the 90s. So as part of a study that I was doing, looking at women with premature menopause, we started looking at the hormone patterns of women with perimenopause. So at the time, I was still cycling, and I called them normal for the mid-reproductive women, how things change. And then peri is in the open circles. But you can see in this group of women, we adapted urinary hormones to reflect what's going on in the serum. So we use those assays because it's much easier to collect a daily urine sample than to get a daily blood sample. And all of these data are standardized to the time of ovulation to mid-cycle in the two groups. So you can see LH looks pretty similar. FSH is higher, which we know as women age reproductively, it takes more follicle stimulating hormone to get the follicles to grow. And to our surprise, estrogen metabolites were higher through the cycle in these perimenopausal women, not lower. We always think of this failing ovary as this sort of quiet, kind of Whistler's mother knitting in a little rocking chair waiting for her ovaries to just like go to sleep. But that's not how it works. So there's more estrogen, and we saw significantly less progesterone. So evidence of those changes in patterns were pretty surprising. And then we saw some really wild patterns in individual women. So this is one individual person who we studied over, we did a year's worth of collection, but this is 6 months. And I'm going to do this in Hebrew, going from right to left. Progesterone is shown in the black squares, and you can see there's 1, 2, 3 bursts of progesterone production. So there were 3 ovulatory episodes over these 6 months, and they are accompanied by what is a normal looking mid-reproductive estrogen curve here, a robust one here, and here estrogen production is about 7 times what we see in a normal mid-reproductive menstrual cycle. So there are wild excursions of hormones, and it comes down a little bit more. So you can see that these differences are really pretty large. And any gynecologist who's experienced at that time would say, yeah, this happens in perimenopause. We don't really know why. And gonadotropins, we studied this because we thought we might see clues in the gonadotropin patterns, like they might tell us something, but they didn't really tell us much. They're really passively following what the ovary is doing. So these findings became part of SWAN, which is the study of women's health across the nation that's been going on now for 30 years. We began with a cohort of 3,302 women. My part in this study was to look at the ovarian hormone production and to find the tests that will predict menopause, which I have failed to do. We're still doing the best we can. We're getting closer, but we're not quite there. So these women had annual evaluations for 12 years for multiple physical measures, endocrine outcomes, biopsychosocial factors, a very well phenotyped group of women. There's a serum and a DNA repository. And the daily hormone study, which I'll show you a little bit about, did similar things to what we see here, looking at what those hormone patterns were. So women collected a cycle or up to 50 days for us for up to 10 years. The SWAN cohort is also an interesting cohort because it was the first time that the NIH required recognizing that people of all different ethnicities pay taxes, that we just look at women of multiple ethnicities. So we did that. We studied women that had a uterus and at least one ovary, because the best way to track the way to menopause, and we still don't have a better way, is to go by menstrual cycles. So we had to see menstrual bleeding. They had to be aged 42 to 52. They could not be taking hormones, could not be pregnant, and had to have at least one menstrual period within the last 3 months. We tried to be population-based, and based on doing random phone calls, we did a cross-sectional survey of about 16,000 women, but eventually to assemble the cohort, we needed to do some other methods. So we consider it community-based, not strictly population-based. And it was designed to be diverse by intent. So the way that we thought we would achieve diversity, and that we thought was being clever at the time, was to collect a group of white women at every one of the sites, and then to collect sort of a specialty ethnic group at each site. So what we found was that if you're a white woman in New Jersey, in Elizabeth, where we collected our cohort, you were quite different than a white woman who was in Beverly Hills in one of the UCLA cohort. So we have to adjust for site in all of the things we did in SWAN. We got African-American women from 4 sites. This is all self-identified race and ethnicity, so it isn't using genetics or any other way of trying to identify race and ethnicity. It was just what the women self-declared. And we got a pretty good socioeconomic slice of Black women into the study. So that's one of the real positives we were able to do. The UCLA cohort was largely Japanese American women who were several generations in the US. And the cohort at UC Davis were mostly first generation Chinese American women. In New Jersey, we were tasked to get Hispanic women. And this is about a mixture of about a third Dominican, Puerto Rican, Central American, and South American. We have 0 Mexican women in SWAN. Really feel bad about that since I've come to Colorado, but we tried to get a Mexican cohort and we could not do it. So we don't have the information I wish we did in that cohort. SWAN was also had several sub-studies in it because we had a very greedy set of investigators. So there's a bone sub-study, and one of the main reasons for funding the whole study to begin with was to find the pattern of bone loss that happens around the menopause transition. We know women lose bone at menopause, but when does it happen? How much do they lose? The daily hormone study was to track hormones, see when fertility milestones might change or when key hormone changes happen. There's a detailed heart study. I'll show you some of that data. Every single woman in the cohort was evaluated with different psychiatric measures, but some got an in-depth psychiatric interview and a sleep study cohort with sleep actigraphy. So some of the things we learned from the SWAN daily hormone study were that when you look at luteal activity, again, that progesterone secretion at the end of the cycle, we made decisions as to which cycles were ovulatory and which were not. So the ones with luteal activity are pretty much preserved. And this is 9 to 8 years And you can see there's a little bit of a decrease in luteal activity, but it really, women don't become largely anovulatory almost right up until the very end of the cycle. Another fascinating feature of the menstrual cycle is that despite follicle loss, despite all the challenges, ovulation keeps going on. So this is the slide I call it ain't over till it's over, because this is maybe the last year of cycling, and a good quarter to a third of the women are still ovulating. So theoretically, it may be possible to conceive at the very end of reproductive life, although we know that there are other factors. There's the ovum itself is compromised with age. But boy, if you look at the hormones, they look pretty amazingly normal. Other things that we saw were that there are changes in ovulatory cycles. So this is just looking at the integrated hormone levels of each of those hormones that I showed you. And you can see that progesterone, luteal progesterone, even if you ovulate, tends to go down. So the ovulation is a little less adequate. So the follicle doesn't quite make as much hormone as it used to. LH goes up at the end of reproductive life. FSH goes up more sharply. But again, look at how close to the end of reproductive life it takes to have them really rise. It's the last 2 years where you see those increases as the ovary ultimately fails. And estrogen doesn't really change that much towards the end when you look at the follicular phase of the cycle. And I am going to skip this one and go to this slide, because this is one of the more dramatic slides that shows us what we were able to do, the power of the SWAN study. And Annie Caldwell gets credit for this because she was looking at all these data and said, I'm going to give you one slide that just shows all of this in one. This is all data that's centered on 0, which is the final menstrual period. So now we finally followed the women long enough until all of them got through the transition, which took a good 20 years, and organize everything around that time 0. And you can see some very interesting patterns. So this is the year before and after the final menstrual period. You can see LDL cholesterol rises as it does with age in men and women. But in this late transition, you see this steeper rise. It's a much steeper rise, about twice as steep as it is before or after. And then after menopause, a year after, that curve flattens out again. Sure, it's rising because aging is happening, but it's not doing anything near what it's doing here. We see visceral adipose tissue increasing during the menopause transition. This is a 2.3% change per year, goes up to almost 8% per year in that 2-year period around the final menstrual period. And then it slows down again. Doesn't go quite back to what it did before menopause, alas, but it still continues to rise. Weight and body composition, also relatively acute changes that are associated with that late transition. So this looks terrifying if you're in the back of the room, but these are small changes percentage-wise. There is a small increase in fat mass that happens again during that late transition fulcrum, and a small decrease in lean mass, and then that tends to flatten out again once the transition's over. So something sort of turbulent is happening physiologically that is not exactly linked to estrogen. Some of these things are linked to aging as well, but we do see these changes in the late transition when estrogen changes are going on, but so are other changes. You look at the metabolic syndrome prevalence, it's creeping along at a certain rate. If there were no effect of menopause, it would be here, but it's about twice the rate, doubles, and it stays that way. So this is one change that doesn't seem to revert back. It stays on a not so terrific course after menopause. When you look at carotid intimomedial thickness, a measure of hardening of the arteries, again, nothing happens in the premenopause or early, but in that late menopause transition, there's an abrupt increase in accrual of carotid plaque. And then the rate of increase goes down post-menopause. Again, we see the same type of thing with depressive symptoms. Here's early transition, late transition, where women have prolonged amenorrhea, a peak in depressive symptoms, and then it tends to go down again post-menopause. The the other striking thing that SWAN was able to show is also what happens to bone mineral density, because we knew something was happening around menopause, but didn't really know exactly what. And this is called the transmenopause. Here is the final menstrual period. You can see bone density taking a real dive. It's about a 3 to 5 year period of time. And then it tends to flatten out again, but it does continue to progress. So bone loss will progress after menopause, but not at the same rate, not even nearly at the same rate. And this is much more classic for an estrogen dependent process, because here you see premenopause in the early transition where women are skipping just a few cycles at a time. There's absolutely no change in the spine or the hip. When cycles get more spread apart, 60 plus days of amenorrhea up to that year that defines you as menopausal, you see a much more precipitous drop in bone density. So these data have yet to be applied to better screening guidelines for bone density for women. Because if this is where the loss is happening, but the US Preventive Services Task Force tells us don't measure bone density until you're 65, what's going to happen? I mean, you're going to miss the boat. And there was a very interesting study a year ago from New Zealand that if you actually gave women in their 50s a single infusion of zoledronic acid, you would attenuate this curve. So there may be much better preventive methods that we'll be able to apply to women if we take some of these data into account. So now I'm going to switch gears a little and go to the second problem that came out of the SWAN study, because as we did our first year of analysis on our daily hormone study, again, these are the I hope you're getting bored with these patterns now and you've memorized them. They're fixed in my brain. We looked at women in approximate BMI tertiles, and we noticed that all hormones were lower. So again, like Ernst Nobil's lab, we thought we made a mistake. We're not accounting for something. Let's check for fat mass. Let's check muscle mass, blah, blah, blah. No, this is real. Let's check for creatinine. And with increasing BMI, every hormone is lower, because this is almost 900 women. So everything is statistically significant. FSH is lower. Estrogen, believe it or not, is lower, even though you can't really see it. And progesterone is really where you take the hit with obesity. So we see a big decrease, almost 50% in the integrated whole cycle progesterone production in the cycles as women's BMI go up. And it's a progressive, almost like a dose-dependent phenomenon. So we know that both men and women with obesity have decreased gonadotropins. In men, they have a little bit of a different syndrome. But obese women, the most abiding thing that we've seen again and again is this diminished luteal progesterone production. Women with obesity, this is important because they have longer menstrual cycles. They are less fertile. They're subfertile because they are ovulating. You can see the progesterone's being made, but it just becomes less likely you'll be pregnant, and a little bit of lower estrogen. So we then went back to look at the pulsatile gonadotropin program in obesity. What's driving that ovary? Is that working okay? And when we did that, we saw that normal weight women with a normal BMI have much higher, bigger LH pulses and higher mean levels than women with obesity. And the frequency of the pulses, so the program that's coming from the brain for GnRH in terms of frequency, seems to be perfectly okay. That doesn't change, but the amplitude is lower. So there's less stimulation coming to the ovary. And what I said before, this could be less GnRH. It could be pituitary that's not responding. So we did a GnRH test of women with obesity and gave them a weight-based dose of GnRH intravenously to see what the response was. And these are women with normal BMI, and these are women with obesity. And you can see that there's less of a response. Even if you move this curve up, there's a significantly lesser response to GnRH. So our next idea was what I'll call Captain Obvious. So get women with obesity to lose weight and their hormones will get fine. So we tried to address that to see if obesity-related hormone changes were a state or a trait. And if you reverse obesity, I could not get funded to study, to do a dietary intervention. because I'm not a nutritionist, but I did get funded to do a study looking at women that underwent weight loss surgery. So this was done as I was moving from Einstein to Colorado, and we recruited a group of women that were scheduled to undergo bariatric surgery. They were at least 6 months post-surgery. They had stable weight, and we tried to study them again. So when we looked at how hormones changed after surgery, and it's important to remember at this point that this is effortless weight loss, because there's no willpower food restriction involved. You really just can't eat as much after you've had the surgery. And that may make a difference in some of the findings I'm going to show you later. The shaded area on all of these graphs, again, we've got LH, FSH. I'm switching them around to keep you awake. Progesterone and estrogen here. Those are normal weight controls, and the pre and post are shown here. So pre is in the darker green, better LH, a little bit higher FSH. Progesterone improved, but it didn't leap into the normal range. But a lot of that was because in the Bronx, women with obesity had BMIs of 50. In Colorado, women with obesity have BMIs of like 35 to 40. Like you're not getting to 50. So the weight loss did not go down to normal weight in these women. They still had pretty substantial obesity burden, but theoretically they might have if they got there. Interestingly, because they lost so much fat mass, the estrone conjugates went down, but that's probably because of estrone being produced in the fat. When we measure urinary estrogen, it's really a combination of estrone and estradiol. So this was encouraging, and then that led to several studies that have been done trying to see if behavioral weight loss would achieve an improvement in fertility in women. So there was one large study, randomized clinical trial done in the Netherlands, and that showed that behavioral weight loss resulting in a weight loss of about, I think it was about 16 pounds, about 6% weight loss, that was done over a course of 16 weeks, resulted in worse fertility outcomes than control. A study done in the United States that I was part of in the Reproductive Medicine Network did the same type of intervention, and we saw no improvement with behavioral weight loss, even though it was successful, 6% weight loss. And Annie Caldwell put this together in a systematic review last year that we published, and we did not see a huge effect for pregnancy. So 13 of the studies that she evaluated with live birth outcomes, not statistically significant for live birth. And there's actually a signal for more miscarriage. So we don't really understand why this is so, but one of the hypotheses that Annie is actively investigating is that there may be some psychic stress to the behavioral weight loss that actually inhibits the reproductive system, and that makes it harder to get pregnant. And this just shows a little more from the systematic review, but you can see that there is not a huge effect for a lot of these interventions, which is kind of disappointing. So that led us to look back and think about the physiology of what's going on here. So we know practically diets don't really work. So if you're going to do behavioral weight loss to help someone get pregnant, you have a limited amount of time, because less than 10% of women and men successfully lose weight and keep it off. It's almost impossible to do it behaviorally. If they don't work and they don't improve fertility, then what are we doing telling all these patients to lose weight? Surgical weight loss has mixed results, although it probably does improve hormones. You see less gestational diabetes and less macrosomia, but you will get more growth-restricted babies. So we wanted to ask some other questions. How does exposure to obesity influence what's happening? Is the cycle of conception somehow, does that set that pregnancy on a worse course, more prone to miscarriage? What's happening at the different levels of the reproductive system? And are there specific agents that we could target? So we call this the reprometabolic syndrome of obesity, but it's resistant to improvement after behavioral weight loss. Negative energy balance may make this worse. RCTs don't support it, so we started to hypothesize and do some physiologic studies. So we thought that the combination, what's happening in obesity is you have more insulin, you have more circulating free fatty acids, and is this leading to the decreased gonadotropins and less GnRH responsiveness that we see in the reprometabolic syndrome? And as I was pondering whether I could ever get anybody to give me money to do this, would the taxpayers pay for this? Wendy Court directed me to Irene Schauer, who had a group of patients that she had treated in a diabetes study she was doing. She had controls that had gotten an infusion of insulin and free fatty acids. And I said, can I have your serum and look at the gonadotropins? And she said yes. And they looked like they were suppressed. So it looked like we might be on the right track. So based on that, we did get funding. And this was the longest RON in history because it spanned COVID, but we survived it and we got the studies done. So we decided to duplicate the experiment that Irene had limited data on because we didn't have the kind of granular pulsatile gonadotropin data we wanted. So we did a frequent blood sampling study over 6 hours. And that's the here and here. This is for LH and FSH. We infused insulin and lipid in one cycle, and the participant came back. She was randomly assigned, and we gave saline in the other cycle. So you can see what happens here is that we suppressed with the insulin and lipid infusion response to GnRH. We also seem to almost immediately suppress FSH and the GnRH response to FSH. So we thought we're on the right track. We may have something here. Now, our sample size was kind of small, so we didn't achieve statistical significance on all of these endpoints. And then when we saw it again, we thought, what are we missing? We had hypothesized that this was due to some inflammatory signal coming from fat that was possibly causing the reduced pituitary response. So we did a multiplex assay for cytokines, and we saw very little. This is kind of a nothing burger slide. We looked at about 36 cytokines, and we saw MIP1B was decreased. That's about it. Everything else looked like no difference at all. So then we worried, were any other pituitary hormones affected by the free fatty acids and insulin? And the answer to that was not really. So we saw some small changes, and Rosie McDonald published this. And Andrew Tanis gets credit for the cytokine study, former resident and former postdoc. And we didn't really see any changes. We looked at TSH, prolactin, growth hormone, free T4, T3, cortisol, adiponectin, IGF-1, and only leptin, which you kind of would expect that after insulin and free fatty acids, that would go up. So then the most ambitious part of this, and the most ambitious study I think I've ever done, and thanks to my lab team and having a CTRC such as we have, that you could even carry something like this off, was that we tried to flip the script and reproduce this reprometabolic syndrome in normal weight women by feeding them a high-fat diet. So if our hypothesis was correct, we could recreate this, and we had the metabolic kitchen produce 1 month's worth of a eukcaloric high-fat diet with 50% calories from fat. It didn't have a change in calories because I tried it for 2 weeks because I couldn't recruit anybody, in all honesty, and tell them that they weren't going to gain weight, because no one would ever do my study if I couldn't look them in the eye and say, you won't gain weight if you do this. And then we examined gonadotropins. We did the urinary sampling to get daily. We did a GnRH response test. We looked at pulsatile gonadotropins. And we also wanted to see if we changed insulin sensitivity. So we also did a 2-stage hyperinsulinemic euglycemic clamp. We did some exploratory examination of metabolo and microbiome changes. And again, you can't do these things in a place that doesn't have these cores where people will do this stuff with you. So this just shows you the paradigm. It was pretty arduous, and we did convince 18 women to do this. So we did a pre-cycle study. We did baseline measures. They collected a control cycle following their normal diet. We got urinary hormones on them every day, and we did the frequent sampling study, GnRH test. The next day, we did the 2-stage clamp. They ate the high-fat diet for 1 month. They ended it at the end of cycle 3, where we repeated the frequent sampling study and the GnRH test. And in the middle, they came in weekly to pick up food. And we did a couple of extra cycles because Teresa Powell, who reviewed this beforehand, said, you better make sure these cycles come back to normal. What if you really disrupt them? Which we hadn't thought of. So we did that. And what we found was that if you go from baseline to the end of the diet, nothing changed in terms of weight. Yet when we looked at all of the hormones, we pretty much changed everything, except unlike the infusion study where we infused the insulin and free fatty acids in normal weight women, we saw big FSH changes. We didn't see such big changes in mean FSH, but the response to GnRH, that pituitary inhibition, it looked like that was confirmed by consumption of the high-fat diet. No change in body weight at all, no change in LH pulse frequency. So the GnRH program wasn't changing. And we thought we would see a change in LH pulse amplitude, but we actually didn't. So the LH pulses themselves didn't change, but we have switched to a new assay that I think is a little less sensitive. So here just shows you the gonadotropin patterns again, baseline in Bronco colors, pre and post diet. And you can see that we suppressed post diet, a little less LH and less response to GnRH. Same thing for FSH, lesser response to GnRH post diet. So now we knew we had an effect, but we don't have a candidate molecule. There was some initial data that possibly oleic acid was one of the things that was particularly toxic to the pituitary, but that turned out not to be true. So we did some metabolomic studies, and we saw, and you can see when you look at these heat maps that there's obviously a change in pattern pre, on, during the diet, and by the end of the diet. And we saw a number of markers that are associated with oxidative stress. And here you can see some of the pathways that were affected. And I don't know if my little volcano plots here are going to show up. But alas, they are not. So having seen those effects, we're moving on to the next step, which unfortunately, due to the government shutdown, is proceeding in a COVID-like fashion because grants are being held up, reviews aren't happening. But we wanted to initiate a low-fat eucaloric diet to determine the degree to which we could reverse those hormone changes that we see in the reprometabolic syndrome of obesity. So we put in RO1, it got reviewed, we put it in again, we got a 9th centile, which in normal times would have a chance of getting funded, and which currently does not. So we have just resubmitted that. And we'll see if that has any, and this slide is for you, Dr. Riley, because these are the things I've done with the support you've given me to re-up some of the research. We have gotten a collaborative foundation award with UNC and VCU from the Cohen Foundation to study epigenetic aging in perimenopause because of what we saw in that late perimenopausal period, those dramatic changes. We are going to do an aggressive, like a holistic intervention for late perimenopausal women, treat weight gain, hypertension, lipids very aggressively, treat menopausal symptoms, prevent metabolic syndrome, and check epigenetic aging before and after the 18-month intervention. The hypothesis is that we will slow epigenetic aging and that it would otherwise be accelerating at that period of time. And the last project, not totally related to all of this, is really about using pulsatile FSH in refractory infertility due to the two problems we really haven't been able to deal with yet in reproductive medicine: obesity and low ovarian reserve. And we do have preliminary data for both of the RO1 grants, the first and third, that these approaches may be successful. And when I'm not doing that, I'm going to be looking at the sunset on the island of Bonaire, which I will be doing in January, February. And again, I can't stress enough what, trying to be a chair and doing your research is kind of like, hey, I'll just work 150%. And being able to work 150% only happens when you have a wonderful team, a lot of support structures around you, and a chance to really rock it. And that's really what I have had the great privilege to have. And I just want to thank everybody on the research team. You see a lot of pictures up here, but Andy Bradford, Alex Polatsky, Irene Schauer, who I've mentioned, but Catherine Kuhn, Shannon Pretzel, who is no longer here, but recruited for that study, statisticians that have worked with it, Angela, fellows that have worked with us, students that have worked with us, and Mary Samuel, who I left off this slide, along with the Metabolomic Core, NORC, and some of the other resources that have been here, but a really wonderful group of colleagues that have made all of this possible. So really my most deepest thanks to everyone. So we are going to do some Q&A.
Can open up for Q&A.
Hold your question until the microphone gets to you, though.
Thank you. Nicole Rathman, endocrinology and metabolic bone, but I'm not asking a bone question. How much of this do you think is going to be mitigated by estrogen? As you and I have talked about so many times, we are seeing this surge of women come in now who really feel like they missed the boat on so many things. They stopped their hormones because of WHI. They're in their early 60s now, and they want to go back on estrogen. And we've always feared doing that, kind of 10 years after the menopause, et cetera. So with these changes that you're seeing, do you think estrogen could help or hurt? Do we not know? And how are we going to figure this out and help advise these women?
Yeah, it's really the question of the hour, really, given where the media is going. When I see those changes, those acute changes that are happening, that settle down again, that tells me that there's just something that's unique to the perimenopause itself that's not necessarily estrogen related. But when I see the things that change and stay that way, those may be estrogen related, right? So those things we might be able to change. We know estrogen's not a weight loss drug. There's a lot of media influencers out there saying that with no evidence at all. If anything, you gain a couple of pounds when you start it. And it's very far from a panacea. The most recent study by Joanne Manson that came out in JAMA last month looks like it is net neutral if you start it in your 60s, which they did in the WHI for symptomatic women. But is it really logical? For women who have symptoms that don't go away and nothing else works, it may make sense, but clearly in your 70s, it's no longer a good deal. The harm outweighs any benefits you may get. Now, that said, I now get the referral practice of everybody who is in their 70s who says, you're going to have to rip this out of my cold, dead hands because nothing else works. But it's all really about what every individual's particular, set of symptoms or risks look like, that you may mitigate them. But we know we're not going to do anything miraculously good to lipids. We know that estrogen seems to have a time-limited effect on improving endothelial function, which also changes along with LDL and CIMT right at that same time point. So that's going to be a limited intervention. And it is not the cure for everything. Neither is testosterone. Black box or no black box.
Thank you, Nanette, for a lovely presentation. It was great. You've showed us that window of perimenopause really is where things are changing in the most rapid rates. But how do we know when women get there? I mean, you said when you started, you haven't identified the marker for menopause, but how are you counseling women that you're getting into that window and this is when we need to intervene?
Well, if a woman is cycling and she's not taking hormones, then you have a pretty good way of telling. So once a woman has achieved 60 days of amenorrhea, then she's in the late transition. So she's then in that chute. And that's what we're actually aiming our epigenetic study right at that point. We're trying to identify women that are there to look at them and intervene. because that is a point of time when symptoms are at their maximum also. I didn't talk much about symptoms, but that's when hot flashes reach their peak. So that's quite often when women are driven to the office. And quite often, other complaints aren't addressed. These other physiologic things don't get addressed. So that really is the time. For women that use an IUD, you can try an AMH level and they give you some insight. It has some use. It's not absolute, but it may tell you that, if it's low enough that a woman is in that point. And women who are using combined hormonal contraception, you're not going to be able to, you just can't tell.
Brilliant presentation and congratulations on your award. What's known about the GLP-1 receptor agonists in terms of how it's going to affect reproductive function and pulsatility?
We can't get our hands on it. I have begged repeatedly to try to get it in a reproductive setting, and no company wants to give it to you. They're very afraid that it will have some adverse effect. We also have to stop it in like assisted reproductive settings because of the slowing gastric emptying. You could have a problem during anesthesia, during an egg retrieval or something like that. So patients have to stop it a month before they begin treatment. So that's really very frustrating. We do know that women lose weight pretty nicely with GLP-1s in the menopause and perimenopause. And it does look like some data that I've seen that's not published, and some data from Stephanie Fobion and Cassandra Schufelt looks like if you are taking hormones, you actually have a little bit better weight loss with things like tirzepatide. But I'm hoping you're going to answer that for us, Ed, with your metabolic flexibility study. So.
Along those lines, I feel like we just barely started thinking about sex differences. So when will we actually put menopausal women into a whole different category from normal weight, middle-aged women or normal young women because of their metabolic differences and their hormonal differences?
Yeah, I mean, I think it's a really important question, and it actually speaks a little bit to what Nicole was saying before, is that if we don't lose this concept of a menopausal woman as being like woman taking away estrogen, like the estrogen hokey pokey has happened, and that's the only thing that has changed, we're really missing out so much on appropriately treating people.
Do I need it?
You might be the only person who doesn't need it.
I'm actually interested in knowing within your studies on obesity whether you've looked at in the obesity group women who have and have not experienced prolonged childhood sexual abuse.
We've been doing some work on, we have not looked at hormones in ACEs. And it's a great idea because we can do that in the SWAN study. So yeah, you just gave my R25 scholars a new project.
It's practically never asked. And there are clear long-term impacts that have been pretty much ignored.
It's quite possible that they're reproductive because, Tracy Bale and Neil Epperson are doing some studies on this, looking at whether ACEs advance your reproductive schedule. And we do know that girls that come from traumatic environments have puberty earlier because, and the thinking, the anthropology behind that is if things are this adverse, you better get reproduction over with or your species won't continue. So that may be true in both men and women. So does that advance the reproductive program? There's some evidence that adversity by social determinants of health causes menopause to be a little bit earlier. But specifically ACEs, I don't know. I know Rebecca Thurston has looked at it in SWAN, but she's looked at it with symptoms. We know your symptoms are worse, but I don't know that we know ages at menopause in those women or exactly what the reproductive hormone patterns look like.
So Nanette, has anybody tried to make a score, a composite score, almost like a Caprini score, your risk for venous thromboembolism after surgery or perioperative, where you take, seems like there's bone data, there's metabolic data, there's reproductive menses data, and, you know, perimenopause, like taking your AMH level, time to final menstrual period, your bone density, your BMI, your like inflammatory scores or anything like that exist, or that they could create with all this AI and algorithm?
To predict morbidity, or to predict?
I guess to predict anything like morbidity, you can predict time somewhat, right? Pretty accurately with the AMH levels, and you know, it'd be great to study pelvic floor with that too.
Yeah, no, there's a few people looking, well, you know, because of the data that you know of, that it looks like pelvic floor stuff gets better across the menopause transition, but that's because there's a wave of badness that happens before the transition, so that goes away, and that's like the first wave of pelvic floor issues, and then it happens again later in life. So scores for different outcomes probably are possible. There's an AI expert at MIT now who just got funded to do this. We tried with Phyllis Wise to get a big U19 funded a few years ago that would have done something similar, but we wanted to look at a lot of biometrics. So she has access to a bunch of different biometrics, like looking at an Oura ring output or something like that, might predict time of menopause, or it might predict how bad your symptom experience is going to be, because we know that, you know, 80% of women have hot flashes, but only about 25% of them are really, you know, rendered, you know, sorely inconvenienced. But that group is pretty, you know, vocal, and for some of them, for about 5%, they never quit. So being able to predict that would be helpful.
Nanette, in your acknowledgement slide, you mentioned the CCTSI. Would you mind characterizing how the CCTSI affected your research?
Oh, sure. Having the ability to do these frequent blood sampling studies, admitting the patients, being able to give them, you know, meds through, you know, and the nurses are incredibly helpful there to do that. So doing the diet exchanges. So not only is it good just to do your screening and baseline stuff, but actually doing the meat of the study. Because if you have to do blood sampling every 10 minutes, you know, I used to do this for 24 to 48 hours in some of the other studies I've done, but I had to give that up because it was just, it's too wearying, much as I'd like to have that data. So we do these 6-hour windows, and the staff supports that. I mean, you just could not do that. I would not be able to put enough personnel into a grant to be able to do that. So it's a huge asset. Having the access to the metabolic kitchen to be able to create this diet. You know, I get to meet with Janine. We go over, like, what do you need? How are we going to do it? And it's done. So yeah, superb staff and just really great support.
Wonderful talk. Very interesting. You know, we're thinking a lot about kind of the menopause transition, or the menopause, just one day in time. You showed some figures that suggested that the 1 to 2 year period surrounding that was very important. But I wonder whether the menopause transition or the length of that might vary among women, whether some women might have a shorter span that they're actively going through a transition, while other women, it might be a much longer, 5 or 10 years, and whether that might relate to any health effects or things like that.
Yeah, we haven't figured that out, but Pangaja Parmasathy did a study with me and Siobhan Harlow. We looked at when your transition starts. So if you start with this sort of irregularity earlier in life, your whole transition is going to be longer, and therefore it's going to be more likely to be more symptomatic. But that late transition, those 60 days of amenorrhea to your final menstrual period, is pretty much never more than 4 years. Like 95% of the time, it's within 4 years. So it's kind of captured in that window, and that's where most of the stuff changes. So I think it's more the severity. And I also think, you know, I know we've had 100 conversations about this. There's also probably an intersection of the age changes, because there was a multi-omics of aging paper that came out a year ago from Stanford that showed at both men and women at age 45 and 60, there are some changes that are rather acute. So aging is nonlinear. And that nonlinear blip that happens at 45, I think we don't take that into account. So to the extent that those changes in any one individual interact with these estrogen-related or late transition-related changes, that may really be more profound. That's why we're going after all these omics and the stuff that we're looking at, and why I think you're going to hit gold with polygenic risk scores changing.
Do we have any more? Might be one more question. Be our last question, right?
The oscillation data that you provide is really interesting. I personally have never seen that before, so that's really cool. I'm wondering, just from a physiological point of view, what do you think the function of that is? And are those oscillations occurring? I think you said every 6 hours the urine samples were taken, or why? What is with those big fluctuations? I mean, they're more so on the left. On the right, they were not quite as distinct, but.
So I think that you have to have that pulsatile secretion, because otherwise you won't be able to maintain gonadotropins. They'll just go away on you. And then you wouldn't be able to go cycle to cycle, because you saw those pulse patterns slowing down under the influence of progesterone, and they have to speed up again. So when hormones are withdrawn, then they speed up again. I think it allows the cycle to propagate itself.
You got them all. Well, what a wonderful discussion we've had this afternoon. I'd like to say that there's a reception in the auditorium just outside the lower level here. We'd ask you to join us. Did you want to have some groups come down? Just
Lab picture.
So we have the lab group come down, and let's end with a strong round of applause.